Welcome, dear friends. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite video site, MuniMeterHealth, currently being shown on several social platforms, as now clearly gaining momentum for enhancing medical education, patient education, to improve the clinical outcomes, which has been my deepest belief. And now it's a global initiative via MuniMeterHealth. So I appreciate your watching us and learning and sharing with your friends. So once again, without any further ado, I'd like to delve into the subject matter. The subject matter here today is VSD. By the way, some housekeeping rules. This is not a substitute to your syllabus, so please use it as a supplement, dear medical students. And of course, my colleagues also. Likewise, for patients, I'd like to say this is not a medical advice channel. This is totally an educational and a informational channel, if you will, and utilizing only for your own health and illness and education per se. And three, if you're having an emergency, if you're experiencing anything like that, then please call for an ambulance, and if you're in the United States, dial 911. So pushing the housekeeping rules aside, let's get to the subject matter. Here, this is the top of the view from the heart. If you wanted to see the heart from the top, now this is the frontal view. This is an interior frontal view. You know the right side of the chambers, right atrium, right ventricle, left atrium, left ventricle. As you know, there are 4 chambers in the heart. The defects are ventricular septal defects that we're going to be talking about. They're basically a failure of union of this ventricular septum, which is the wall dividing the right ventricle and the left ventricle. This is your right ventricle, and this is your left ventricle, the big guy. There's the booster chamber sitting right here. It's a very, very important chamber, by the way. Okay, so just remember that left ventricle is the one which is communicating directly with this guy, the aorta, and sending the blood from head to toe. So now you have different defects that can occur, namely 4 defects, but I'll just outline there. There could be sometimes more than one defect in one single patient. So, but there are four anatomical reasons or anatomical locations where the defects can be. So when you're looking from the top of the heart, now this is from you're looking from the, say, top of the heart right here. This becomes your right atrium. This becomes your left atrium, because right atrium and left atrium, you see that, and here is a little, I would say, a ridge here. Same where the pulmonary artery is anterior to the anterior. So this is your front of the heart, and this is your behind of the heart, if you will, or the back side of the heart. This being the right side of the heart, and this being the left side of the heart. Clear? All right, so you're looking at the heart from the top, like you're looking from the house from the roof upwards. So on the top from the roof. Okay, I can be more clearer than this, I hope. So let's see now. So the tricuspid valve, or will appear in this fashion. The mitral valve, which is a bicuspid valve. The only that's a good question, board question for the medical students, the second, third year medical students. The only valve which has only 2 cusps is the mitral valve. Remember, it's also called bicuspid. I'll write it down because it has only 2 cusps. I've shown 1 and 2. Others have 3, as you see. And so there are 3 cusps in all the other valves except the mitral valve, which has a bicuspid, which is a bicuspid valve. So now let's see where the defects can occur. So when there's a failure of union somewhere between the tricuspid and the mitral ridge, if you will, or somewhere between right here. See the tricuspid ridge right here? This is your tricuspid valve. This is your mitral valve. I've shown only 2 leaflets here. There are 3 leaflets here. So this ridge, the brown one, which is corresponding to this one, is number 1. And which one is that? That's the AV canal defect. Okay, you don't have to remember all the names, but just so that you know, there's a defect right here between which is, again, remember, it's all happening in the ventricles, in the bottom chamber. So this is the ventricular septum. We have discussed ASD in another video, so please look for ASDs in there. Here we are looking at the VSDs, because that's where the ventricular septal defect, or a hole in the bottom of the chambers of the heart, is being depicted. Now, the schematic here corresponds to this one here. So that becomes number 1, and that's AV canal defect. Okay. The second one will be the membranous defect, and that will occur somewhere where? Let's see here. This is your second membranous defect right here. And that's slightly lower than the AV canal defect. Now, when you're looking at it from the front of the heart, you can see it more in perspective in that fashion. So as you see, you're descending down towards the apex of the heart. This is the base of the heart. This is the base, and this is the apex. I'm just writing it down for the students here so that you remember. So base is right here, and this is your apex of the heart. So when you're looking at from the front of the patient here. Okay. Third defect will be the malalignment defect, very rare defect, and that occurs right next to the pulmonary and the aortic, almost where they are originating from. So this becomes your number 3, which is your malalignment defect. And the big guy is the fourth defect, that is the conal septal defect. And sometimes there may be muscular defects later on here, because this area is the muscular septum, and the top area of the septum is the membranous. So the basal portion of the septum is mostly membranous, but the muscular portion is here, obviously, because you want to have more muscle here so that the flow of the blood going up into the from right ventricle into the pulmonary artery, and from the left ventricle into the aorta is contributed by more muscle than by membranous. Membranous is here because that really anchors it well at the ridges, at the tricuspid mitral valve ridges. So now you know the 4 defects. Once again, quickly: AV canal defect, membranous defect, malalignment defect, and the conal septal defect, the 4 varieties. Now let's look at the classifications on the right side of the panel here. Well, obviously, if it's a small at neonates and at birth, now this is the failure of closure of the ventricular septal wall that occurs during the time when the child is growing in the mother's womb. So when it's a small defect, it's classified as less than 4 millimeters. Anything between 4 and 6 millimeters is roughly a moderate size defect. Just remember that. Small, moderate, and the large is more than 6 millimeters. So more than half a centimeter, more or less, will be a large defect. Now, smaller the defect, the lesser will be the shunt volume that will traverse from left ventricle to right ventricle. Why? Because the left ventricle is always having high pressures, right ventricle has low pressures. Just remember that. So the volume will be less in small defects, as opposed to the large defects. It'll be vice versa. You'll have more volume going in there. Now, which will be the noisiest shunt? The noisiest shunt will be the small, because you have a small aperture. So it goes. That's a holosystolic murmur that traverses straight between left to right shunt, and that'll be between systole. So holosystolic murmur is a holosystolic murmur. It's all through the entire systole, if you will, and that's occurring between S1 and then S2. So this is where the murmur would be, and then followed by a diastole. This is your diastole, this is your systole. Systole is the contraction, diastole is the relaxation. So the murmur will sit somewhere here. If I can draw it here quickly, I'll show it to you here. So it's a holosystolic murmur occupying the entire systole, if you will, like this, starting from S1 to S2 all the way. Okay, so that's very different than the murmurs from ASD, which we looked at in a different video. So these are systolic murmurs, holosystolic murmurs, very harsh many a times, and again, depending upon the intensity, they could be 2/6, 3/6, and I've defined murmurs in another video also. So just so that you know, the smaller the murmur, the smaller the defect, the harsher the murmur. Okay, whereas the large defects, remember, a moderate size will have a moderate 2/6 or 3/6 murmurs, but large defects, because the larger the defect, if you have a bigger defect, a small defect, you'll have the pressures will be higher, obviously, and the murmurs will be louder. But if you have large defect, what happens? The volume flow will be huge, no question about that. So that's the volume, but the defect, the murmur may be absent. It may not be present at all, or it may be very, very mild. Why? It doesn't make so much of noise going through from a larger door. As it's very simple. Like if you have a door which is slightly open in the house, it'll make more noise. Or a window which is slightly open and the wind is blowing through, it'll make more noise, like that. Whereas a smaller defect will be like that. Okay, so that'll be a smaller defect, but it has larger connotation. Remember, it has negative prognosis. Why? Because you have larger volume going there. So it's the opposite here. So just remember that. Another way of classification is here, where the QPQS ratio. Now, this is for the medical students, residents, and fellows, and especially the cardiology fellows taking the boards. They will ask you a question: where do you want to operate? You want to operate somewhere here, you want to operate somewhere here, or you want to operate somewhere here. Now, once the QPQS ratio is more than 2.3, there is no surgery happening. Why? Because you have a right ventricular volume overload and a pulmonary hypertension already existing here in this individual. So no surgery is happening here. QPQS less than 1.3. If it is symptomatic, you may want to operate, and 1.3, 2.3 is definitely you want to operate these patients here, because sooner or later they'll develop more than 2.3, and that may become very irreversible rather. So here you can reverse that, because once the right to left shunt occurs, the cyanosis, the clubbing has occurred, the pulmonary artery atherosclerosis or arterial stenosis, which is irreversible at that point, can develop, and as a result, the sclerosis and pulmonary hypertension becomes irreversible, and you don't want to operate then, because it's going to be pointless. Even if you close, on the contrary, things may actually worsen. So the whole idea is wanting to operate somewhere here or here. Okay, so just so that you know. And of course, the QPQS ratio is the volume of flow that's traversing through the pulmonary circuit compared to the systemic circuit. Normally the pulmonary and systemic circuit should be the same, obviously, because whatever is going to the pulmonary is going to the systemic. Remember that. That's as simple as that. So the ratio normally should be 1 to 1. That's QP. But when it is 1.3 in QPQS ratio, or when it increases from 1 to 1.3, that is considered as a small shunt. This is considered as a moderate shunt, and this is more than 2.3 is considered as large shunt. Okay, so just a quick review on a VSD on this video vignette, primarily just to brush you up, so that this way when you go for your tutorial classes, your quick exams, you have a quick take on it. And as I said, the louder the murmur, the smaller is the shunt, but the shunt volume increases as the defect increases in size. So just remember that as the defect increases in size, you'll have more volume of blood going through, and that's more significant. So you want to operate those cases as early as possible before the pulmonary hypertension sets in. And I've defined all these 4 locations of these various defects. You don't have to remember all the names, but just so that you know, the AV canal defect is right on the top here, and then next to follow is the membranous defect, then the third is your malalignment defect, and then of course you have the congenital septal defect. Okay, all right, wonderful, and thank you for your attention again, and looking forward to seeing you again on my next video. Keep promoting medical education, patient education together, please, so that we can improve the clinical outcomes in our patients. And as I always say, a learned customer is the best patient for the medical doctor. Why? Because you can have a better grasp, a better adherence, better compliance on all your medications, and understanding of your disease, and both in health and illness. Okay, thank you again. So long, and stay well, and stay with MuniMeterHealth, your favorite